Good morning to everybody. I am going to talk about hepatitis delta. Hepatitis D or hepatitis delta is the most severe form of viral hepatitis. If you compare the risk of progression to chronic hepatitis, to cirrhosis, and also hepatocellular carcinoma, and need of liver transplantation is much higher in those patients co-infected with hepatitis D than those only monoinfected with hepatitis B. The issue of hepatitis delta is that in the majority of cases is under-recognized. And if you look at the distribution and the prevalence of hepatitis delta, there are two different studies saying that the prevalence of this infection is quite different. 4.5% of the population, HBs antigen population infected by Delta in one of the studies. That means about 12 million of people worldwide. And the other study is much higher, it's 14%. That means 43 million of people infected by hepatitis B. Only patients with hepatitis B can be infected by hepatitis delta. And the prevalence of hepatitis delta has been modified in the last year due to the impact of hepatitis B vaccination. In countries, in high-income countries with a good implementation of hepatitis B vaccination, the prevalence of hepatitis delta has been decreased in the last year, and there is a surviving cohort of older patients with advanced liver fibrosis or cirrhosis. However, in countries, in middle and low middle income countries where hepatitis B vaccination is not fully established, there is still a high number of people infected by hepatitis D. And if you like to identify the hotspot countries for hepatitis D are Mongolia, Moldova, some countries of East Asia and Sub-Saharan region, and some African regions. These are the red countries. The problem of hepatitis delta is that in the majority of countries, testing for hepatitis delta is limited, and only some populations has been tested. In some countries, only blood donors. In other countries, patients attended liver clinics, and the prevalence is completely different if you look at blood donors, that is very low, or if you look at patients with liver disease, that is much higher. There is no agreement on guidelines regarding testing for hepatitis delta. The American Association for the Study of the Liver guidelines recommend testing only for those HBs antigen positive patients with risk factors for hepatitis delta. That means usually drug addiction or be part of these countries with the highest prevalence of hepatitis delta. Other guidelines, such as European guidelines have specific guidelines for hepatitis B, and now a new guidelines only for hepatitis delta recommend testing all HBs antigen positive. A puzzle, only patients with chronic hepatitis B and liver disease. And the current WHO guidelines not specify about testing for delta. How to test? The recommendation is start testing for anti-delta antibodies, and if these antibodies are positive, then testing for viremia, because testing for viremia is the only way to confirm and to diagnose active delta infection. Anti-delta antibodies, that is the first step for testing for delta, are not available in all countries, and this is a limitation for testing for delta. Even in the US, there is not there is no test approved for hepatitis delta. That clearly limits to understanding the epidemiology of hepatitis delta. We performed this study 1 year ago in our center, and we look before introducing reflex testing in a similar way that we use for hepatitis C. We test in Barcelona how many of people, HBs antigen positive people, were tested for Delta. And even the recommendation of European guidelines that is testing all HBs antigen positive. Even with this recommendation, the rate of testing at that time was very, very low, only 6%. Then we apply reflex testing for all HBs antigen positive serum samples that our lab received, and we increased testing for Delta. And we found that reflex testing increased the diagnosis in 5 times. There is a 5-fold increase in diagnosis in Delta. And what for me it's even more important is that 60% of patients with anti-Delta antibodies and viremia positive have no risk factors for hepatitis Delta, or at least they didn't report any risk factor for hepatitis D. We continue working on this, and this study recently accepted for publication clearly shows that reflex testing reduce hepatitis Delta liver complications, decrease the early diagnosis, decrease the risk of liver disease progression and HCC and liver-related death. And it's also cost-effective, because this is also an important point to see if testing once time for Delta is cost-effective, and here the study shows that it's cost-effective. The second part is the factors associated with disease progression. And the factors associated with disease progression are viral factors, host factors, and also, and very important, the presence of cirrhosis. Regarding viral factors, the most important factor is the presence of viremia, of Delta viremia. And regarding host factors, the typical host factors that are advanced HIV infection and the presence of cofactors, alcohol, diabetes, obesity, and immune deficiency. One of the best studies regarding the probability of developing clinical outcomes is this study performed in Italy some years ago with a large number of patients with hepatitis Delta and with a follow-up of almost 20 years. And the study shows that persistent viremia is associated with disease progression. And this is important because this is clearly the goal of treatment, to suppress viral replication. And then if we are able to suppress viral replication, then we can prevent or we can change the prognosis of patients with chronic hepatitis Delta. So what is the current recommendation for treatment of patients with hepatitis Delta? So the current recommendation is to treat, or at least to consider for antiviral treatment, all patients with chronic hepatitis Delta, even those with decompensated cirrhosis and those with hepatocellular carcinoma. Currently, we have 2 drugs for treatment of hepatitis Delta. One is PEG interferon and bulevirtide. PEG interferon has never been approved for treatment of hepatitis Delta, but has been used for a long time, and there are different studies showing the efficacy of interferon, but very, very few, only 2 randomized phase 2 studies published. The current recommendation is to consider the treatment with interferon for those patients that have chronic hepatitis with or without liver cirrhosis. And this is a strong recommendation. Treatment duration 48 weeks, and probably in some patients, treatment can be personalized depending on HBS antigen kinetics and treatment tolerability. What is clear, and these are results of 2 studies, that PEG interferon in some patients achieve undetectable viremia, and these patients with undetectable viremia have a longer survival and a better clinical outcome. Bulevirtide is the new treatment approved in Europe, only in Europe. It's a first-class entry inhibitor, and it binds to the receptor that allows the entry of hepatitis B and hepatitis delta virus into the hepatocytes, and blocking these receptors, then there is a decrease in the number of hepatocytes infected with hepatitis D. This drug has been approved by the EMA based on phase 2 studies and ongoing phase 3 study. And in these studies, monotherapy with 2 milligrams with bulevirtide have shown the best efficacy. So for this reason, the ISL has recommended the use of bulevirtide for patients with chronic hepatitis delta and compensated liver disease, but we still have some doubts because the studies are ongoing regarding the optimal dose and duration of treatment, and if the combination of PEG interferon and bulevirtide could be considered in patients with chronic hepatitis delta. And to support these recommendations, that some of them are still weak recommendations, I would like to show the results of the ongoing studies in patients with hepatitis delta. This is the phase 3 study. In this phase 3 study, 2 different doses of bulevirtide, 2 and 10 milligrams, has been evaluated for at least 3 years of treatment. It's a multi-center, open-label study. Patients with or without liver cirrhosis can be included. And some months ago, the results of 2 years of bulevirtide therapy has been presented, and the result shows that there is no or very small difference in terms of efficacy between 2 milligrams and 10 milligrams of bulevirtide in terms of virological response, defined here by undetectable HDV RNA or more than 2 log decline in the levels of viremia with normal ALT levels. The safety profile of this drug, that is also important, is excellent. There is no specific side effects, except because it's a subcutaneous drug. Some patients presented injection site reactions, and also because this receptor is also the receptor of the bile acids. There is a transient increase in bile acids during treatment, but this increase in bile acids, it's only during therapy, and it's completely reversible when therapy is stopped. The second approach is to combine bulevirtide plus PEG interferon, and this is the final results of a study, a randomized study in a relatively small number of patients that evaluate monotherapy with PEG interferon, monotherapy with the high dose of bulevirtide, 10 milligrams, and combination of bulevirtide, 2 milligrams or 10 milligrams with PEG interferon. And the study shows that combination is superior in terms of undetectable viremia. Here the endpoint is stronger, it's undetectable viremia, it's not 2 log decline. And I think this also clearly supports the use of combination therapy. Regarding the safety of combining bulevirtide and PEG interferon, that it's also important. There is no additional adverse events and are very similar to those observed with PEG interferon when these two drugs are combined. Finally, in addition to these studies, we have a lot of data on the real world. These are data from France, but there are data from Germany, for Italy, for Australia, and the real world data evaluating both monotherapy or even the combination of PEG interferon plus bulevirtide are very, very similar to those observed in the clinical trials, are similar in terms of efficacy and also in terms of safety. So in summary, and to be on time, the current prevalence of hepatitis delta remains poorly understood worldwide, particularly for the low rates of screening. Patients with chronic hepatitis delta, particularly those with active viremia, have more rapid progression to cirrhosis, hepatic decompensation, and hepatocellular carcinoma. Reflex testing increased the rate of hepatitis delta screening and helps to better understanding the global burden of the disease, and also, at least in our hands, can improve hepatitis delta outcomes. EASL guidelines recommend both PEG interferon and bulevirtide for treatment, and the dose up to now recommended is 2 milligrams because it's efficacious and safe in patients with compensated chronic hepatitis delta. And the real-world studies confirm the results of clinical trials, even in patients with advanced fibrosis. And I would like to leave with, if you like to have more information on hepatitis delta, I think the clinical practice guidelines on hepatitis delta are very well updated, are recently, and you can download free by the EASL webpage. Thank you very much.